السلام عليكم ورحمة الله وبركاته. Welcome everyone.
السلام ورحمة الله وبركاته.
عليكم السلام ورحمة الله.
This is
Good morning,
our
doctor.
new course, which is a preparatory course for European Board and Subspecialty Examination. Let's to start Diabetes Mellitus section. Actually, initially, I would like to thank my dear friend who sent this message. I am a pediatric consultant in Arabia Saudi and received a lot of courses in MRCB in pediatrics, and this is the first time to see a course like this. MashaAllah, effort and regulations, and hope Allah make you safe. Thanks for you. And actually, I already upload this survey in our Google Classroom, and actually, most of you select Friday as a time. But still, there is a significant number choose to be PM. So I will check the attendee and then I will see this later. Don't forget, my survey in the Google Classroom is very important to improve this course. So please, for everyone, please try to follow my survey and respond to it, because it may make a difference in some decisions. Don't forget this. This course is exam-oriented course. This is not ordinary course as the previous, but it will be exam-oriented. I will focus on the most important items related to the exam. I will provide a lot of the materials for everyone to improve his experience in endocrine. Not for only the exam, but for your clinical practice. So this is practical, this is advanced, this is exam-oriented course. And of course, in all of my courses, tools, files, videos are not for redistribution. Don't redistribute my materials. It is for your personal use only. And actually, as I mentioned in every time, my presentation is interactive. So any question at any time are welcome. Please do your comment, do your respond, and any question at any time are welcome. Through chats, through WhatsApp, through email, through Classroom, Google Classroom, by any method, any question are welcome. And actually, your reply to my post in Google Classroom is very important. Today, I will start diabetes diagnosis and general management. And actually, this and the next session will represent 28 questions from the final exam. So the first two sessions in this course will cover 28 questions of the final exam. So it is very, very, very important. The most important two sessions is the first and the second one. It represents about 14% of the final exam question. And actually, I will cover this from this page to this page in the Oxford Handbook. And also I will cover from my El Zohra SC and European Board Endocrinology notes the first and the second chapter. The first chapter, which will cover a diagnosis, classification, and genetics of diabetes, which is very important. And the second chapter, which will cover assessing in newly diagnosed diabetes and expert management of type 1. I will focus on the most important items related to the exam and to clinical practice, and inshallah, I will cover a lot of questions. Let's start by Elliot Jocelyn Hand. In the self-management, education in diabetes. This is a father of diabetes education. He mentions that the diabetic who knows the most lives the longest. So try to educate your patient well. Education is the cornerstone in the management of diabetes. The knowledge you gained, you should transfer it to your patient in clinical practice. This is very, very important, especially for type 1, especially how to avoid hypoglycemia, how to treat diabetes in the sick day rules, how to avoid hyperglycemia, how to avoid complications. This is mandatory. This is essential part in the management of diabetes. Let's start by the first chapter, diagnosis, classification, and genetics of diabetes. This is a very important topic in the final exam. Let's start by this case scenario. If you see a case scenario like this is usually repeated in all previous exams. They usually ask about interpretation of diagnostic values for diabetes. This is a male, 52 years, presented with a labs. Fasting plasma glucose is 7.3 millimole. Don't forget this. In the UK, millimole per liter. This is the unit for fasting random plasma glucose oral glucose tolerance test. And hemoglobin A1C is 47 millimole per mole, and this is also another unit for hemoglobin A1C, not percent. They usually in the final exam put millimole per mole and percent in some situations, but not routinely. In most cases, they usually put percent and millimole per mole for hemoglobin A1C, but usually they prefer this unit. And ask about interpretation of this result. If the fasting is 7.3, is it in diabetic range or normal values? Hemoglobin A1C is 47 millimole per mole. Is it normal or diagnostic for diabetes or pre-diabetic or high risk? This is a very essential question in the final exam. So what is your opinion? Which is the most appropriate interpretation according to the NICE diagnostic criteria? Can we diagnose diabetes on the basis of fasting plasma glucose alone? Of course, no. We cannot depend on a single value, even if very high. Option B, diabetes mellitus can be diagnosed on the basis of hemoglobin A1C alone? No, this is not accurate. Diabetes mellitus is confirmed because both results are diagnostic. We need to know the cutoff value for diagnosis by fasting and hemoglobin A1C. Don't forget this. In fasting, the diagnostic value for diabetes should be more than 7. What about hemoglobin A1C? Should be more than 48. So, in fasting is in diabetic range, but in hemoglobin A1C is not in diabetic range. Can we diagnose diabetes by only fasting? Of course, no. So, diabetes mellitus is confirmed because both results are diagnostic? Of course, no, because hemoglobin A1C is not in diabetic range. Repeat testing is required to confirm diagnosis? Yes, this is the correct one. If we have two values, one in diabetic range and another in non-diabetic range, we cannot diagnose diabetes. We need two abnormal values. The exception is random plasma glucose more than 11.1 with symptoms. So if we have random blood glucose more than 11.1 with symptoms suggestive of diabetes, we can diagnose diabetes. So actually, in this question, results are constant with impaired fasting. No, fasting plasma glucose is in diabetic range. So option E is not correct because fasting is in diabetic range. So why I put this question? because knowing the cutoff point values for diagnosis of diabetes is mandatory for the final exam. So again, in asymptomatic patient, a diagnosis of diabetes requires two abnormal results or two concordant abnormal tests. So if we repeat hemoglobin A1C in 2 different days and both values are in diabetic range, we can diagnose diabetes. If we do fasting, which is in diabetic range, and hemoglobin A1C in diabetic range, or 2-hour post-oral glucose tolerance test in diabetic range, we can diagnose diabetes. So this, in our case scenario, repeat testing is required. Again, we should be familiar with these numbers. This is very important for diagnosis of diabetes. Diabetic range, hemoglobin A1C should be more than 48 or 6.5%. Fasting more than 7 millimole per liter. If we need to convert to milligram, we should multiply by 18. A 2-hour oral glucose tolerance test should be more than 11.1. Random should be more than 11.1 with symptoms to be diagnosed. So don't forget, we need to memorize 3 numbers. 48 is a diabetic range, hemoglobin A1C, fasting more than 7, 2-hour more than 11.1. And actually, this is not a slowly number to be memorized. We need to be familiar with the normal range, because we have normal range and we have diabetic range, and in between we have what is known as high risk patient or a pre-diabetic. Don't forget this. In UK, they not use a pre-diabetes term. They usually use high risk patient or non-normal hyperglycemia. So as I mentioned previously, a diabetic range for fasting more than 7. The diabetic range for 2-hour is more than 11.1. For random, 11.1. For hemoglobin A1C is more than 48 or 6.5. The normal fasting is different in the ADA versus in NICE. This is important. In NICE, normal fasting and WHO is less than 6.1. This is the normal fasting. In the American Diabetes Association, they use 5.6 for normal fasting, which is equivalent to 110 milligram. This is the normal fasting in the UK. The normal fasting, according to the American Diabetes Association, is less than 100, which is equivalent to 5.6 millimole per liter. This is a difference between in NICE and in ADE. In between 6.1 and 7 is impaired fasting or high risk patient. So impaired fasting, fasting should be less than between 6.1 and 7. This is impaired fasting. Another value is 2-hour post-oral glucose tolerance test by 75 gram anhydrous glucose. Diabetic range is more than 11.1. In normal, less than 7.8, which is equivalent to 140 milligram per deciliter. In between, impaired glucose tolerance. So, impaired fasting, we should have fasting between 6.1 and 7. Impaired glucose tolerance test, a 2-hour should be 7.8 and 11.1. With less than 7 impaired fasting plasma glucose. A random has only diagnostic value, and hemoglobin A1C has also a different normal according to the NICE, normal less than 42 millimole per mole, which is equivalent to 6, but in the American Diabetes Association, normal hemoglobin A1C should be less than 5.7. So this is important. Dr. Marina Nashat asked a question in this previous question. If we have elevated fasting and hemoglobin 1C, fasting is elevated, hemoglobin 1C in the normal range, which test should be repeated? Actually, most guidelines recommend to repeat the elevated number. So in this case scenario, we should repeat fasting plasma glucose. But if you do another, for example, oral glucose tolerance test is not usually recommended routinely. Oral glucose tolerance test has a specific situation to be done. But if we do oral glucose tolerance test, we will have fasting at 2 hours. But in this case scenario, if we have two results, we should repeat the elevated values. Yes, Dr. Omar. Dr. Omar, soon if fasting is abnormal, just repetition the fasting and confirming abnormal, you are right. Random, if we have random more than 11.1 with symptoms, we can diagnose with this only one value. So random is usually ordered in symptomatic patients. Don't screen for diabetes by random plasma glucose. If you need to screen, we should do fasting or 2 hour or hemoglobin 1C. Random is not used in asymptomatic patient. This is a malpractice. And if we have a patient with symptoms of suggestive of diabetes, we can order hemoglobin random plasma glucose, and if more than 11.1, we can depend on this single value for diagnosis. Again, الفاستنج normal less than 6.1, الdiabetic range is more than 7, in between is impaired fasting. 2 hour in normal is less than 7.8, الdiabetic range 11 more than 11.1, in between impaired glucose. If we have a patient with impaired fasting and impaired glucose, in this situation, it should be termed impaired glucose only. So impaired, if we have impaired glucose tolerance test and impaired fasting, it is impaired glucose tolerance only, not impaired glucose tolerance and impaired fasting. We should follow the term, it is impaired glucose tolerance test. And as I mentioned, this is termed high risk patient in the UK. Again, this is illustration summarize the abnormal and the normal values. Yes, a random should be ordered in symptomatic patient, not routinely. So again, fasting in normal less than 6.1, this is the UK, in the ADA less than 5.6, diabetic range 7, in between impaired fasting. 2 hour, we have normal less than 7.8, diabetic range 11.1, in between impaired tolerance test. Random, we have no normal random. If more than 11.1, it is a diabetic range with symptoms, it can be diagnosed for diabetes. And this is important. If we have impaired fasting, the risk of development of type 2 diabetes mellitus in the next 5 years will be 30%. If we have impaired glucose, the risk will be double in the next 5 years. So don't forget this, because it may be a question in the previous exam. And another very important hint, if we have high risk patient or a pre-diabetic, what is the most important method to prevent diabetes? Lifestyle management, weight loss. And this is a repeated question in the previous exams. What about LADA? LADA is rapidly progressive type 2 diabetes mellitus. It is a slowly progressive type 1 diabetes. So LADA, or what is known as latent autoimmune diabetes of the adult, is a gray zone between type 1 and type 2. It has manifestation of type 2 like insulin resistance, like improved with oral therapy, not insulin resistance. It will be controlled with oral therapy like type 2, with positive autoantibody like type 1. And the age of onset is usually more than 30 years of age. So اللادة should be diagnosed in the adult age more than 30 years of age. And the patient is not require insulin therapy in the first 6 months of life after diagnosis. Random or stimulated C-peptide, دكتورة مارينا, الامريكان Diabetes Association in this recommend random C-peptide. Consider C-peptide, the recommendation is random C-peptide, not fasting or post-prandial. This is a random C-peptide. This is a protocol of stimulated C-peptide. As mentioned here, actually, we can measure a C-peptide in a random fasting and stimulated, and this is the method for stimulation. And everyone has a specific cutoff point values. But in routine assessment of type 1 versus type 2 is random C-peptide. And so this values for random C-peptide. So اللادة should be diagnosed after the age of 30. Some references recommend more than 35. The auto antibody against 65 should be positive. Not require insulin therapy in the first 6 months. This is a type 1 if required insulin in the first 6 months. They usually controlled with oral therapy, but rapidly require another medication and insulin after 6 months. So اللادة, which represent about 5% of diabetics, is a slowly progressive autoimmunity, adult more than 30 or 35, with some feature of insulin resistance. It is in between type 1 and type 2. Again, there is some sort of insulin resistance like type 2, with autoimmunity positive like type 1, leading to LADA diabetes. So another very important term is ketosis prone diabetes, KPD. As you know, a type 1, 25% of type 1 will be presented with diabetic ketoacidosis. The type 2 diabetes is rarely presented with DKA, but in some situations of type 2 may be presented with DKA. This is known as ketosis prone diabetes. Will be presented with DKA and should be managed as DKA protocol for type 1. But later on, insulin requirement is declined over weeks and months with negative autoantibody and can be managed with oral therapy as type 2. This is a ketosis prone diabetes. So, if a patient is presented with DKA, it may be type 1 or ketosis prone diabetes. If a patient was presented with autoantibody, it may be type 1 or LADA diabetes. This is very important. So, how we diagnose ketosis prone DKA patient with negative autoantibody? We need to assess C-peptide. After DKA resolution, it will be in a normal range, and the patient should be assessed and treated by oral therapy. And of course, we have different form of ketosis prone diabetes according to the autoimmunity and beta cell reserve, C-peptide. The most common form is negative autoantibody with a normal beta cell reserve. So as there are a lot of subtypes of ketosis prone diabetes. Dr. Omar Mustafa mentions that ketosis prone diabetes is common in Egypt. Actually, not a very common, but if we have a patient with obese, family history of diabetes, and they present with DKA, we should suspect ketosis prone diabetes in this case scenario. But if we have a lean body weight, no family history of diabetes, and DKA, we should suspect type 1, and we should treat with basal bolus. Type 1 is important. The most diagnostic to differentiate between ketose and type 1 is autoantibody. This is the most important one. In autoantibody, especially if we order more than one autoantibody. The GAD65 is the most important one. We can order the transporter insulinoma associated autoantigen type 2. If one or more autoantibody is positive, it is with type 1. Type 1, the age of presentation around the peak, around the puberty, and another peak around 5 to 6 years. And don't forget that in the Oxford Handbook, this is written incorrectly in this location. So, the age of presentation of type 1, the peak around the puberty and peak around 5 to 6 years. 70% of type 1 has a 3 to 4 positive antibody. Presence of 2 more or more autoantibody, or one with supportive clinical picture confirmed type 1. Absence of this autoantibody, we should consider other etiology. In insulinoma associated antigen 2, very specific for type 1. Zinc transporter very early after disease onset, very early will disappear after disease onset. We should screen for microalbuminuria and after 10 years. For the pediatric type with type 1 at puberty or after 10 years old, whichever is earlier, and diabetes duration more than 5 years. So screening of microvascular complication for type 1 is very, very important. We have a lot of autoimmune disorders linked to type 1. The most common one is thyroid disorder. So all guidelines recommend assessment of autoimmune thyroid disease at diagnosis of type 1 and in annual basis. So any type 1, once we diagnose, we should assess TSH and anti-TPO. If normal, we should repeat every 1 year. Addison is another autoimmune disorder, may be presented with diabetes and should be assessed by morning cortisol and short lactate test if symptomatic. Celiac disease assessment is important because 5 to 10% of type 1 will be presented with celiac disease. Nice guideline, recommend assessment for celiac disease at initial diagnosis for all type 1, but later on if symptomatic. The American Diabetes Association has a different protocol for assessment of celiac, but the UK should assess celiac at diagnosis by TTG IgA and the duodenal biopsy of positive, and later on only if symptomatic. Gastritis and pernicious anemia is common with type 1 and should be diagnosed by CBC macrocytic anemia. Vitiligo alopecia areata is also a common autoimmune disorder associated with type 1 and should be diagnosed clinically if in a person. So it is very important to know this. This is from the American Diabetes Association about recommendation for screening and treatment of complications of the related condition in pediatric type 1. And I will mention the difference between a NICE and the American recommendation. A thyroid disorder should be screened initially and every year by TSH and anti-TPO. When to start soon after diagnosis, and then every annual or every 1 to 2 years. And if abnormal hypothyroidism, we should treat with levothyroxine. Celiac, we should screen with TTG IgE. If total IgA is normal, we can screen with TTG IgG and deaminated gliadin antibody if IgA is deficient. So if IgA is deficient, we should order IgG. If IgA is normal, we should order TTG IgA. When to screen? NICE and the ADA after diagnosis, at diagnosis. In NICE will not recommend the follow-up celiac screening except if there is a SAM. The American Diabetes Association require follow-up within 2 years and then at 5 years after diagnosis, sooner if symptomatic. The hypertension should be screened at diagnosis and then every visit. The dyslipidemia should be non-fasting sample after diagnosis, preferred after glycemia has improved and more than 2 years old. And if there is some sort of LDL less than 100 milligram, we should repeat at 9 to 12 years for type 1. Nephropathy by ACR, albumin to creatinine ratio, and I will discuss this, which is random sample, should be screened at puberty or 10-year. Summary of the today's session, which is very important. The diagnostic criteria is mandatory to be familiar with these numbers. Don't forget this: 7 for fasting, 11.1 for 2 hours, and random 48 for hemoglobin 1c millimole per mole. In normal fasting, NICE less than 6.1. In between impaired fasting, progress to type 2 is 30% in the next 5 years. A 2-hour normal less than 7.8. In between impaired glucose. If we have impaired fasting and impaired glucose, it is impaired glucose. Normal random, we have no normal random. It's just cutoff point for diagnosis of diabetes. Hemoglobin 1c normal less than 42. In between high risk patient. Don't forget factors that affect hemoglobin 1c. Carbamylate hemoglobin increase falsely elevated by 5 to 10%. Iron deficiency anemia falsely elevated. Blood transfusion, hyperinsulinism, erythropoietin falsely low. Don't forget, if the mother is type 1, the risk will be 1 to 2%. If the father, the risk will be high, 6%. Father and the mother, the risk will be 25 to 40%. The concordance, 50%. The concordance rate for type 2 is 60 to 100%. This is important. Don't forget, Ilmode diabetes, it is autosomal dominant. HNF1 alpha, low renal glucose threshold, glucosuria plus 2 or 3 with normal plasma glucose or mildly elevated, treated with sulfonylurea. HNF for alpha, hypoglycemia, macrosomia, neonatal hypoglycemia, hyperinsulinemia, treated with sulfonylurea. Glucokinase, it is usually in the exam, glucokinase is a moody with the pregnancy. It is a glucokinase usually. But if you see a moody with a pregnancy with a renal cyst, it is HNF1 beta. If you see a renal cyst, moody with pregnancy, with a history of macrosomia or neonatal hypoglycemia or hyperinsulinemia, it is HNF4 alpha. Otherwise, it is a glucokinase. Mild, stable, fasting hyperglycemia. Glucokinase lead to phosphorylation of glucose. Should be treated with no treatment in pregnancy, may require insulin therapy. In mitochondrial diabetes, it is maternal inherited. The cause is sensorineural deafness. Should be treated with insulin or DPP4 inhibitor. Should be assessed with echo, audiology assessment, and genetic testing is required for final diagnosis. Again, an autoantibody is positive in 80% of type 1. 2 to 5% of type 2 may be positive, get 65. If we have 3 autoantibody, 80 to 90% will progress to develop for type 1 in the next 10 years. Autoantibody is not done routinely at diagnosis of type 1, except if we have atypical presentation. LADA is positive, get 65. Age is more than 30 or 35 years. Not require insulin in the first 6 months. Ketosis prone, negative autoantibody, type 2 with DKA. Type 1, age of presentation around peak, around the puberty, and another peak around 5 to 6 years. And this is a question in the previous exams. 70% of the patient will be presented with 3 or 4 positive antibody. Screening of microalbuminuria after 5 years of diagnosis. The risk of weight gain is less with detemir. The hypoglycemia risk is less with degludec, followed by glargine, followed by detemir. Daphne is an educational program for type 1. Dose adjustment for normal eating. Desmond for type 2. Nice recommend for type 2, Desmond, and expert for type 1, Daphne and Daphne Plus. Don't forget the carb count. We should start with initial number for adults with type 1 insulin to carb ratio. 1 unit will cover 10 grams of the carb. This is the initial starting point. If they mention another number, we should follow this number. Insulin sensitivity factor, we should use 1 unit of the insulin will reduce the plasma glucose by 3 millimole per liter. It down, Sumuji. Both of them, morning hyperglycemia. It down, 3M is elevated. We should increase the basal. Sumuji, 3M is low, so we should decrease basal insulin. I think this is the last slide in my presentation today. Inshallah, in the next Friday, I will announce about what I will cover in the next Friday. But actually, I will cover 3 sessions from this from Google Classroom for everyone in my who subscribed for this course. Please join a classroom, Google Classroom, and inshallah today I will upload this session inshallah after Salat al-Jum'ah inshallah. But for everyone, I would like to go to the Google Classroom. How we can go to the Google Classroom? From your Google account like this, you can go to this one and then Google Classroom like this. I will choose Google Classroom. I would like to put then this one 2026. This is my course classroom platform. We can go to the classroom like this. You will find some survey like this. Do you speak Arabic or not? This is a just survey for me to improve my course language. You will find the most important one. Today's discussion will be uploaded in this port. The previous discussion for 2025, this port. Today I already covered these 2 topics, this one and this one. Inshallah, in the next Friday I will cover number 3, 4, and 5. So you need to be review these materials, and also in my notes I already covered this. This is my notes. This is 1. I cover 1 and 2. Inshallah, in the next Friday, I will cover 3, 4, and 5. You need to be review these materials. If you have any question, you can comment. You can do any comment for my presentation. If some point is not clear enough, please let me know, and I will answer it, inshallah, as soon as possible. And another very important topic I will announce about this. Actually, I am working on this exam recall, and I will mention what I do in this exam recall actually. And once it prepared, I will upload it for my course subscriber. This, for example, is the exam recall for the previous SC European Board exam. This is exam recall. I already prepared it for the European Board 2025. This is the exam result. I think the result of this exam will be appear today. Actually, this exam is since 6 weeks, so I think the result is released today. In this file, I already work about a specific test scenario and do some explanation and do a lot of infographics for every question. But I will add more and more very important tables and data related to the question. For example, in this question, this is a question related to the Charcot arthropathy, neuroarthropathy. And we have a different differential diagnosis: osteomyelitis, osteoarthritis, Charcot, septic arthritis, gout. I put infographics like this and do a lot of tables like this to differentiate between osteomyelitis, osteoarthritis, Charcot, and gout, and so on. And another question, if you see a question like this, for example, hypoglycemia in a diabetic patient, I put a very important approach, how to approach for hypoglycemia in a very practical and clinical manner. And I put a table like this: non-diabetic hypoglycemia differential diagnosis, and the clue for every one as a differential diagnosis. And another one, for example, I would like to announce about it. For example, a patient like this, a question like this. A question asked about a patient on GLP-1 and getting pregnant. Of course, we should stop GLP-1. I add an extra data related to the endocrine drugs to be stopped before a pregnancy. In diabetes, we should stop GLP-1, we should stop SGLT2 inhibitor, we should stop pioglitazone. In the thyroid, we should stop carbimazole, we should stop anti-androgen, and a lot of data related to the topic. For example, if you see a case scenario with bariatric surgery, I add a lot of data related to the bariatric surgery and data. And another data which I already added to this exam recall is CGM interpretation. And actually, I will do a separate topic related to the CGM interpretation. This is a question related to the CGM graph. And after that, I put a lot of data related to the practical guide to interpreting CGM or day graph profile. The first step to assess, and then step 1 interpretation, overnight, and then postprandial, and so on. So this is a very, very important actually data related to the exam, and it will be very beneficial for everyone. And after that, we have another graph, and I put another data approach to modify insulin doses using a daily CGM graph, and I will give announcement and a lot of hints about it in this course, inshallah. And actually, I do, for example, a question related to the statin therapy, and I put another data statin therapy for people with type 1 diabetes. Actually, a lot of data like this is not in my notes, original notes. So I will try to add some of them to my notes and upload it later, but it will be in the exam recall. So exam recall will be beneficial. For example, in this case scenario, this is a case of obesity and hyperphagia, and mentioned a lot of syndromes which is important in the final exam, Prader-Willi or